Hello, my name is Judy Schack Dugre, and I've been a licensed physical therapist for 30 years. I've not only watched but experienced the transition from a biomedical approach to patient assessment and intervention to one that is inclusive of psychosocial influences. The literature is full of empirical evidence that support the efficacy and efficiency of clinical practice that incorporates the biopsychosocial model with patients experiencing low back pain. Much of today's clinical practice guidelines are still driven by looking for a mechanical dysfunction or a disease process origin. What we typically don't address is fear avoidance. How does someone's belief actually affect their reality? As individuals, we use inductive reasoning when we consider pain. If I bend over and hurt myself, I'm not going to bend over anymore. So then what happens? Our realities drive our experiences, our brains get rewired, and our functional mobility is now limited or altered. So they feel like they're getting worse. There is an instrument out there called the FABQ, the Fear Avoidance Belief Questionnaire, and it was developed by Waddell. If you Google it, it should pop right up. It's very, very easy to find, FABQ. And this instrument is specific to this patient population for use in the clinic. And what it does is it provides the clinician with improved understanding of how fear is actually, what component fear is playing in the limitation of your patient's function. So regardless of what kind of therapist we are, athletic, occupational, physical, of course we need to address mechanical or disease processes, but we also need to consider fear beliefs. As we slowly progress activity, especially aerobic exercise, to increase a pain threshold, this provides opportunity for your patient to slowly increase their function. Their pain may or may not decrease. However, you will find they will slowly be experiencing a greater quality of life because they can do more before the pain sets in. Thus, they feel like they're doing better. So what does this mean for all of us? We really do need to take the time to educate our patients and the support of others and redirect their understanding of pain to include a contemporary comprehensive pain model that includes defining pain as having an emotional component with actual or potential tissue damage, and the patients need to understand this. Without this understanding, fear can drive a lifetime of pain and functional limitation. So incorporating the use of the biopsychosocial model for this patient population is one worth investing our time and our efforts.